Dengue fever is a mosquito-borne viral infection, arbovirus, that poses a significant health risk worldwide. The infection may be 1. Asymptomatic dengue fever, or 2. Dengue hemorrhagic fever without shock, 3. DHF with shock. Dengue and DHF is endemic in more than 100 countries in the WHO regions of Africa, the Americas, Eastern Mediterranean, SE Asia, and Western Pacific. The SE Asia and the Western Pacific are most seriously affected. More than 2.5 billion people, 2/5 of the world's population in these regions are at risk. An estimated 50 million infections annually, with 500,000 people with DHF hospitalizations. Please visit the WHO and CDC website for current global and local updates respectively. Agent factors. The disease is primarily transmitted through the bites of infected Aedes mosquitoes, especially Aedes aegypti and A. albopictus. A. aegypti is anthropophilic, nervous feeder. It needs more than one host to complete its feeding and also its life cycle. These results in multiple cases and clusters. Transmission of the disease. The Aedes mosquito becomes infective by feeding on a patient from the day before the onset of the 5th day, viremia, of illness. After an extrinsic incubation of 8 to 10 days, the mosquito becomes infective for life. Environmental factors. The population of Aedes mosquito fluctuates between rainfall and water shortage. Its lifespan is influenced by temperature and humidity, survives best between 16 to 30 degrees centigrade and a relative humidity of 60 to 80%. It's endophagic and endophilic. It breeds in the containers and around the house. Epidemic factors. 1. The strain of the virus. 2. The density, behavior, and vector capacity of the vector population. 3. The susceptibility of the human population. And 4. The introduction of the vector into a receptive community. The dengue virus has 4 distinct serotypes. All 4 serotypes are able to produce DHF, but only 2 to 4% develop severe disease. DENV1, DENV2 sequence has 500-fold increased risk of DHF. DENV3, DENV2 is 50-fold risk, while DENV4, DENV2 has a 50-fold risk. High-risk patients' factors are infants and elderly, obesity, pregnancy, hemolytic disease, congenital heart disease, chronic diseases such as diabetes, patient on NSAIDs. DF may be asymptomatic or manifest as phyllo, DHF, or D-shock syndrome. In classical DF, all ages are affected with children with milder disease. Incubation period is 3 to 10 days, commonly 5 to 6 days. DF is the severe form of dengue. The illness can be divided into 1. Febrile, 2. Critical, and 3. Recovery phases. Read up the clinical diagnosis and treatment on the World Health Organization websites or standard public health textbook. It is important to note that for a probable diagnosis, these must be present. Acute febrile illness with 2 or more of the following: headache, retroorbital pain, myalgia, arthralgia, bone pain, rash, hemorrhagic manifestations, leukopenia, thrombocytopenia, and rising hematocrit, and at least one of the following: 1. Supportive serology on a single titer. 2. Occurrence at the same location and time as confirmed cases of DF. For a confirmed diagnosis, a probable case with at least one of the following: 1. Isolation of dengue virus from serum, CSF, and autopsy sample. 2. 4-fold or greater increase in serum immunoglobulin G or increase in immunoglobulin M specific to dengue. 3. Detection of dengue virus genomic sequences by RT-PCR. 4. Detection of dengue virus antigen in tissues, serum, CSF by immunochemistry or enzyme-linked immunosorbent assay. Please read up dengue shock syndrome and clinical management of dengue. Preventive measures against dengue are primarily focused on controlling mosquito populations and avoiding mosquito bites. This can include using insect repellent, wearing protective clothing, using mosquito nets, and eliminating standing water where mosquitoes breed. As a community physician, you need to pay attention to the prevention and control of dengue in the community. Think dengue when you are thinking about malaria, and do not always dismiss every fever as malaria. It could be a dengue. We return shortly to some of the control measures. Currently, only one vaccine is available for dengue prevention. WHO recommends the use of Dengue TAC-003 in children aged 6 to 16 years in settings with high intensity of dengue transmission. The vaccination course consists of 2 injections given 3 months apart. Please check the World Health Organization website for more information about dengue vaccine. Control measures, very important. 1. Mosquito control. The same control measures for malaria vector is used here, targeting both the adult and larval stages. Any successful control effort must be centered on the ability to sustain the intervention with sound monitoring and evaluation. Control of dengue vectors has mainly been approached by source reduction. Elimination of container habitats that are favorable oviposition sites and which permit the development of the aquatic stages, by tightly fitting lids or covers on containers, or by killing larval and pupal stages using insecticides. Carrying out pupal surveys in human habitations can identify which containers are most productive. Treating only these productive containers can be as effective as dealing with all containers, but is far more efficient. The ability of the vector to exploit unconventional sites to rest or lay eggs should not be underestimated. In the past few years, for example, breeding has been found in septic tanks and in rooftop gutters. 2. Community surveillance. Ideally, surveillance activities should include the rapid detection of human infection, supported by valid clinical and laboratory diagnosis. Vector surveillance and monitoring of environmental and social risk factors for dengue outbreaks to ensure that increased dengue transmission is detected early and that the response is rapid and appropriate. Effective vector control measures are critical to achieving and sustaining reduction of morbidity attributable to dengue. Preventive and vector control interventions aim to reduce dengue transmission, thereby decreasing the incidence of the infection and preventing outbreaks of the disease. 3. Personal protective clothing and the use of mosquito repellent and treated bed nets. Please read up the global strategy for dengue prevention and control. Visit your hospital viral hemorrhagic fever Research Central for more enlightens and familiarity with the research laboratory. Also visit the WHO, NCDC, and other websites for current updates. In conclusion, as a community physician in Africa, prioritize creating awareness on the prevention and control of dengue as we do for malaria and other arthropod-borne infections. Encourage high index of suspicion among health workers at the primary healthcare centers and a prompt referral to a tertiary or specialist facility where diagnostic and treatment resources exist. For those with an Edo state, contact the Irua Specialist Teaching Hospital directly or the NCDC for the nearest referral center to your location.